My name is David Lee, and I'm going to be talking to you today along with Dr. Adam Golis about bariatric surgery. So this talk is going to go over obesity as a disease, some different treatments of that disease, bariatric surgery and how it works, and then some things you might consider if this is something you're considering for yourself or for someone you love. Just a few words about myself. I've been in practice here in Columbus for over 18 years. My practice is bariatric surgery, and then about half of my practice is general surgery. So about half of what I do is weight loss surgery. The other half is things like gallbladder surgery, colon surgery, hernias, endoscopy, and that type of thing. But really my favorite part of my practice is my bariatric surgery part of my practice. And the reason is when I do gallbladder surgery or hernia surgery, it's more of a short-term interaction. The person comes to see me and I do their surgery, and then they come in and see me one more time. And at the end of that, they really are glad that it's over with, and they sort of wish they never had to come in to see me for that. But for my bariatric surgery patients, they come in having a big problem. We talk to them a lot about their life and how it's going to change. We do a major surgery on them, and then when they come back in a year later, they have all sorts of stories that they tell me about new things that they're able to do. They're not diabetic anymore. They don't have high blood pressure anymore. They have taken their family to Kings Island for the first time. Their kids are teenagers. They've never been to an amusement park because their parent was too big to ride the rides. They've ridden a horse for the first time since they were a little girl. And for me, being able to share in those experiences with my patients is really fulfilling. And that's why I went into medicine, to help people in a permanent way with things that are a real impairment to their health. And so that's why I'm here.
My name is Dr. Adam Golis. I'm one of the bariatric surgeons here at Southern Indiana Surgery. I wanted to start by telling you that our team is excited to play a vital role in your journey to a healthier and more fulfilling life. Please know that you're not alone, as our providers and community of patients are committed to helping you succeed. We would like to start by asking, what was your wake-up call? You may find your situation is relatable to some of our patients' testimonials.
I suffered a fall approximately 3 years ago and didn't break anything, but had sprains. I had a sprained ankle, sprained knee, sprained back, had 2 surgeries, and as a result, I now have chronic back pain and hip pain. I have done everything, medically indicated, and now was at the chiropractor, and he thought by losing weight that would alleviate some of the pressure on my back. I didn't really take him seriously at first, but when I went back the second time, he started giving me brochures. I was like, okay, he's really serious about this. He wants me to really think about that. Then I had to kind of really think about the fact that obesity is a disease. That was a thought process that I just had never ventured to think about before, that this really is a disease and that I'm a person who is afflicted by this disease and have been afflicted by it since childhood. So that was kind of a wake-up call for me, and that I needed to do something.
I think my wake-up call probably was when I realized that my quality of life was declining. And it was going down rapidly. I had diabetes. I had a lot of issues with my breathing, with asthma and joint issues, and life just was not a whole lot of fun to live anymore. So I realized that for me to be able to be there with my kids and to do things with my kids and to just enjoy life, that I was going to have to do something, because I didn't want to keep going the way that I was.
I live on a corner house, and I was sitting outside with my son, who was just learning to walk, and we were sitting on the lawn and just playing, and out of nowhere he jumped up and ran towards the street. And the amount of time it took for me to get up and run after him, he was already in the street. And I realized that I wasn't there to protect him, that I couldn't do it at my weight. So at that moment, I knew that I had to do something so that I could be there for him. He was only 1 year old.
Whatever the reason you've decided to get more serious about weight loss, you're in good company. Obesity is a problem that affects about 1 in 4 people in the industrialized world. 78 million Americans are affected by this disease, almost a third of the people in Indiana. This increasingly common problem has become increasingly more expensive to the point that the CDC has published these maps showing the percentage of people in each state that have obesity as a disease, with light blue being less than 10%, darker blue 10 to 15%, etc. And the reason I show you this is just to show that the country looks very different now than it did 30 years ago, and obesity is a much bigger problem. And so more people are turning to something that honestly is more drastic, like surgery, that'll give them more definitive control over their disease.
What is obesity? Obesity is a disease related to an unbalanced Western diet that leads to excess fat storage known as adipose tissue. This disease causes many secondary health problems known as comorbidities that we will discuss in more detail during this session. Unfortunately, if left unchecked, obesity is a progressive, lifelong problem, and if not reversed, is ultimately life-threatening. What obesity is not a cosmetic problem, although obesity can be disabling in a society quick to pass judgment. Obesity is not a problem with willpower or character flaw. Rather, it is a consequence of a Western diet and food industry with a goal of ensuring you can't eat just one. Obesity is not easily treated with diet and exercise alone, as you may have experienced. Unfortunately, obesity kills. Obesity is a devastating disease that results in an estimated 325,000 unnecessary deaths every year in the United States alone, a population equal to that of 4 times the size of Bartholomew County. Obesity is the second leading cause of preventable death.
Now, when we talk about obesity, we use body mass index or BMI as a measure. While it's not perfect, BMI does provide an objective measure of weight, at least as it relates to height. And it's been shown in medical studies that a body mass index of over 35 to 40 really starts increasing your risk for weight-related illnesses. You might be able to find your BMI on this chart. The height here is on the left side and the weight is on top. BMI of less than 25 in the green is the healthy weight range. Yellow is the overweight category, BMI of 25 to 30, and then BMI of over 30 is the obese category, and then over 40 is categorized as the morbidly obese category. You can see if you look at this, you really don't have to be that much overweight to be considered in the obese category. If you look at someone who's 5'7" and weighs 180 pounds, that person's only about 40 pounds overweight, but they have a BMI of 30 and they're classified as being obese. So even so, people who are just 40 to 50 pounds overweight who have a BMI of 30 or higher have a significant increase in risk of weight-related health problems. They have a big increased risk of death, increased risk of heart disease and stroke, and 4 times risk of a healthy weight individual of type 2 diabetes. And for people who have a BMI of over 50, they have over 10 times the risk of death as someone who has a healthy weight. This disease places someone at 1/3 the chance of living to retirement age as a healthy weight individual. And that's primarily because of these weight-related health problems that are so much more common in people with obesity. Diabetes in about 1/3, high blood pressure in 1/4 to half, high cholesterol in 1/3 to half, heart disease and sleep apnea in 10 to 20%. Arthritis, you're carrying around 100 to 150 extra pounds, your joints are taking a beating. 20 to 25% of people struggle with joint problems. Depression, not surprising, 80%. And women, especially women who've had several children, stress incontinence, really common. A lot of women have menstrual problems where they don't have periods, or they have periods that last 2 weeks, or they can't get pregnant, or they have polycystic ovaries. All these are really common in people who struggle with the disease of obesity.
Weight loss options. There are conventional methods that should be pursued first, as surgery is not the first step. These conventional options consist of diet, exercise, supervised weight loss, and anti-obesity drugs. The conventional approach leads to more of a modest weight loss, averaging approximately 5 to 25 pounds of weight loss, and medications added to this may reach a total of 30 pounds of weight loss. We do think it's important to pursue the conventional approach prior to considering surgery, and therefore this is a component of our preoperative program. Also, surgery is not for everyone. That being said, we also offer a medically supervised weight loss program where we do use dietitians, our psychologist, anti-obesity drugs to help ensure your success with this more conventional approach if surgery isn't best for you. Another approach for weight loss options are, of course, surgical therapy. This consists of, in our program, the bypass and sleeve gastrectomy, which we will discuss soon. Weight loss surgery has shown tremendous success. On average, 50 to 70% success rate seen in the long term at 10-year follow-up. Average weight loss can be as high as 50 to 70% excess weight loss, and even higher than 80% for patients who show a significant commitment to both the conventional methods and the surgical approach. I must say that surgery is a tool, and this tool must be put in play with both the conventional methods.
I always tell all my patients that surgery is not a cure for obesity, it's just a tool. And I'm going to tell you how this tool works. The way this tool works is we do surgery that takes your stomach, which is about the size of a Nerf football, and we make it super tiny. So we make it so that it holds roughly the volume of an egg. And so if you've ever had the thought of, if my stomach was just really small, like the size of a toddler's stomach, then it would be way easier for me to lose weight. And that's how the surgery works. We just take your stomach and we make it super tiny. What that does is it makes it so you're basically never hungry. You know the feeling you get when you've just had Thanksgiving dinner a couple hours ago, and you're sitting around, and if someone were to come up to you and say, hey, let's go out and get pizza, we're all going to go get pizza, and you'd say, well, I could go with you, but I'm really just not that hungry. And they're like, yeah, come with us. And so you go with them, and you might have 3 bites of pizza, and that's really all you could really handle because you're just not that hungry, and honestly, you're pretty full. And that's how your entire life is, because your stomach is really, really small. So it makes you feel full. It makes you feel so you're not hungry. It makes you fill up quickly because your stomach is physically small. Then if people continue to eat, it hurts. And if they continue to eat after that, they throw up. And so it is a very powerful tool to keep people from overeating, to provide good satiety, and to allow you to stop eating when you've had a meal that is literally about the size of like 1 scrambled egg. Now, this makes a huge change in how you have to eat. There is never going to be a time after a bariatric surgery where you could go out and eat a Big Mac. That is completely off the books. There's never going to be another time when you can go out and have a milkshake. That's a huge change. It's a change for things you don't think about. It's a change for how you celebrate Thanksgiving. Thanksgiving's not going to be about having a feast. It's going to be about getting together with your in-laws, who you may or may not get along with. Your birthday is not going to be about cake and ice cream. It's going to be about getting a year older and doing whatever you do. And this weight problem has to be a big enough problem in your mind for you to be able to make a commitment to making these changes, which are big changes in your life. You have to be okay with saying to yourself, I'm never going to have another Big Mac. I'm never going to have another milkshake. I'm never going to have potato chips again. I'm going to be the guy who eats clean and goes to the gym and does CrossFit every day. I'm not the guy who eats Pringles and watches Netflix every day. And it's a big commitment to a big change in lifestyle. Now, I like Pringles and I like Netflix, but if you really want to get a permanent change in your body, you have to make a real commitment to making a real change in behavior to have success. One of my favorite quotes by Einstein is his definition of insanity was doing the same experiment over and over again and hoping for a different result. And I just want to make clear that that's not what we're doing here. We don't do this surgery and then allow you to go home and eat the same way and not go work out. This surgery is just a tool to make it so that you're not hungry. You can really make a huge change in your dietary behaviors. And then when you start losing weight, it starts getting to be easier to work out. It doesn't hurt as much to walk, to run, to get on the bike. And those different diet and different lifestyle changes is what makes people have a different body style and a different body type on a long-term basis.
Am I a surgical candidate? NIH consensus criteria and candidacy for bariatric surgery for most insurers requires a BMI of greater than 40, unless a patient has a BMI of greater than 35 with significant comorbidities, as have been discussed and as will be discussed further during this presentation. Failure to lose weight with a supervised diet and exercise program also could make you a candidate. Compliance with a multidisciplinary program, one such as ours, will increase your ability to be a candidate for this procedure. Compliance with a multidisciplinary program is also required. Availability for long-term follow-up must also be demonstrated, as this is a condition that is lifelong and it is important to continue to have a plan for follow-up with a bariatric provider indefinitely. Females require contraception, or at least a plan for contraception, for a minimum of 18 months post-surgery to ensure the best result for both the patient as well as the developing child. In this slide, we will review your gastrointestinal anatomy. First, you have the esophagus here labeled at number 1. This is where the food initially goes after swallowing. The food then enters your stomach, number 3, which serves as a reservoir and in the early digestive phases of that food. The food then makes its way across the pylorus, number 4, into the early portion of your small bowel, known as the duodenum, here number 5, as you see it wrapping around the pancreas. The food then makes its way down the small bowel, number 6, the early portion called the jejunum, down towards number 7, the more distal portion of your small bowel called the ileum. And finally, that food empties as it's made its way throughout this digestive phase into the colon, number 8, and eventually through the colon to the rectum.
Small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. The surgeon examines the abdominal cavity using a laparoscope or video camera. A small stomach pouch is created using a stapling device. This smaller stomach pouch restricts the amount of food that can be eaten before feeling full. The small intestine is separated into 2 sections. The lower portion of the small intestine is attached to the newly created stomach pouch. This allows food to pass directly into the small intestine, where digestion continues. Bypassing a portion of the small intestine decreases the absorption of calories and nutrients. The upper portion of the small intestine is reconnected to the lower portion of the intestine. The bile and pancreatic fluids from the liver and pancreas allow food to be completely digested.
So the gastric bypass works in 2 ways. Firstly, we take the stomach, we divide it so that the only part that is still attached to the esophagus is about the size of a shot glass. And that part of the operation makes it a restrictive operation. It makes it restrict how much volume you're able to eat at once, so that you can't really eat or drink much more than what goes into a shot glass at one setting. The second part of the operation is where we reroute the intestine. And we use this Y-shaped configuration of the intestine to bring a loop of intestine up to the gastric pouch that we just made, so that food can get into your GI tract, which it ultimately has to. That rerouting makes it also a malabsorptive operation, and by that I mean that all of the calories and nutrients that you eat, not all of them get absorbed. So that makes the gastric bypass potentially a little bit more powerful than the sleeve gastrectomy in that you might be able to eat 800 or 1,000 calories a day with a gastric bypass, and then you might absorb about 80% of those. So you might go from eating 2,000 or 2,500 or let's face it, 3,000 calories or more to being able to eat 800 or 1,000 calories and then absorbing 640 to 800 calories. And so people lose weight like crazy with the gastric bypass. I think the pros of this operation primarily are that the weight loss might be a little bit more than the sleeve. I definitely think it's better for people who have really bad reflux. I think it's a little bit better than the sleeve for people who have really bad diabetes. And I'm talking about people who are taking 2 or 3 medications for their diabetes or on an insulin pump. It has some downsides too. The malabsorption makes it more likely for people to get protein deficiency or vitamin deficiency. And because of the rerouting you see here with the intestine, it increases the risk of a bowel blockage because the intestine can flip around this Y-shaped configuration and cause a bowel obstruction, and then the intestine being attached directly to the stomach increases the risk of ulcers to about 5%.
The average human stomach can expand to hold around 1 to 1.5 liters of food. While in the stomach, food is combined with digestive enzymes to help break down the food into a more simple form so that it can be more easily digested and absorbed once in the small bowel. During a sleeve gastrectomy, a thin vertical sleeve is created by using a stapling device. This sleeve will typically hold between 50 to 150 milliliters, or is about the size of a banana. The excised portion of the stomach is removed. The newly created gastric sleeve is able to hold approximately 1/10 of what the stomach was able to hold before. This smaller stomach sleeve restricts the amount of food you can eat before feeling full. The bile and pancreatic fluids from the liver and pancreas mix with the food and allow it to be completely digested and absorbed in the bowel. There is no rerouting of the small bowel or post-operative adjustments necessary for the sleeve gastrectomy.
The sleeve gastrectomy is one of the bariatric procedures we offer. The pros for this procedure are the patient feels restricted as they have a smaller stomach. This procedure has shown to be reliable with long-term sustained weight loss. It is also shown to have a reduction in some of those secondary medical conditions, also known as comorbidities, where they will often go into remission following the sleeve gastrectomy. One thing that could be looked at as a pro with the sleeve gastrectomy is that it does not have a malabsorption component. The sleeve gastrectomy also offers a physiologic component, as there are hormones made within the stomach that are removed that can lead to a lower appetite. As you can see on the image, and as you also saw in the video, the sleeve gastrectomy is created by removing a significant portion of the stomach, therefore decreasing the size of the reservoir. The size of the stomach following the sleeve gastrectomy can be thought of in total about the size of a banana, but within the actual lumen of the stomach, similar to the size of a garden hose. And this restriction in and of itself leads to weight loss. Some of the cons for the sleeve gastrectomy are nausea, vomiting, and dehydration. This is often caused by patients overeating and can improve once the patients become more acquainted to an appropriate volume of food. The sleeve gastrectomy has a leak rate that is approximately 1%, and the sleeve gastrectomy may not be the best option for patients who have significant gastroesophageal reflux disease. The next series of slides, we will discuss how the surgery works, how it leads to weight loss, the effects it'll have on comorbidities or secondary health conditions, how it helps one's lifestyle, the safety of the surgery, and the side effects and complications that one may experience. This slide demonstrates outcomes for percent excess weight loss over time for the sleeve gastrectomy versus the bypass. Here you will see within the first year there is an exponential weight loss. that peaks at approximately 70 to 80%. Over the next year, the patients continue to have a weight loss, where within the bypass, the weight loss peaks at greater than 80%, and for the sleeve, they have a small amount of weight gain, but then level off and plateau with a sustained weight loss in the distant future. This slide demonstrates the national data, which we just discussed, as well as the data from our clinic. As you can see, the data within our patient population is superior to the data nationally. And we feel this is a reflection of the care that we provide in regards to our multidisciplinary approach and the family-based setting and atmosphere and support that we provide within our clinic. As you can see with both of these trends, there is weight regain at approximately the 3 to 4 year mark, further instilling the importance and underscoring the fact that surgery is just a tool and that one still must implement the conventional methods as discussed previously, consisting of diet and exercise.
Regarding health problems associated with the weight, or so-called comorbidities, in general, if a health problem is associated with being overweight and you lose weight by any means, that health problem gets better. And so the things that are the most well studied are things like type 2 diabetes, which improves in over 80% of people. And when I say improves, it means that they have a normal hemoglobin A1C and don't take any medication. Hypertension improves in between 50 and 90%. Venous stasis disease improves in most people. Osteoarthritis improves in between 40 and 76%. And this surgery does nothing to your joints. It works on your stomach. But simply offloading your joints really makes a big difference. And so if you can find a problem that you have that's on this chart, if you are able to lose weight by any means, a significant amount of weight, then that problem will improve. The thing that makes bariatric surgery so powerful is its reliability in getting a massive amount of weight to come off.
This slide demonstrates more of those secondary health conditions that are related to obesity. Dr. Lee discussed some of the more common, that being diabetes, hypertension, and such. And here I wanted to highlight some that you may not be aware of, such as non-alcoholic fatty liver disease. Non-alcoholic fatty liver disease can lead to progression of fibrosis and even end-stage liver disease in patients who suffer with obesity. Migraines and pseudotumor cerebri are also associated with obesity. Urinary stress incontinence is associated with obesity. Degenerative joint disease, osteoarthritis, knee pain, joint pain. One comorbidity that is not listed in this image is an increased risk of progression to cancer in patients with obesity compared to patients without obesity. Recent studies have shown a 33% increase risk of developing cancer in a patient who is obese. These cancers consist of, but are not limited to, breast cancer, ovarian cancer, pancreatic cancer, and so forth.
I'm not as tired anymore. I seem to be able to accomplish more things in a day. I can do more things with my son. My back pain is not as bad as it was in the beginning because I am working out 3 times a week with a trainer, and these are the hardest workouts I've ever had in my life, and I'm surviving them. That's incredible. Before, after my fall that I suffered, I had problems with swelling joints, swelling ankle, not had any swelling, and I think I can contribute that to the weight loss.
I was on medicine daily for diabetes. I was on 6 or 7 different medicines for my different asthma problems, my different joint pain. Now I'm on one medication, and it's not for diabetes, and it's not for asthma. I just take something to control allergies now. That helps financially greatly, but it gives you just a better overall sense of well-being. And I think to be healthy, to be truly healthy, you have to be healthy physically and mentally. So the two work together, and it just even gives you more of a boost, and you can just get so much more success from it.
I had all kinds of problems. I was on 2 blood pressure medicines. My blood pressure now is down to normal. I was on an antacid because I had acid reflux from the pounds of sugar I was eating. I had sinus pills because I had the CPAP. I don't have to use anymore. I don't have sinus problems, so I'm through with the machine.
It's changed dramatically. My life has changed so much for the better. I feel like a person again. Little things like getting on an airplane and flying. I just feel like a person again. I love shopping. I love hugging my children and running and playing and walking and all the things that I wasn't able to do for such a long time. I just feel like a person.
You know, obviously we've chosen patients to talk about their experiences who have had really positive experiences. And I don't want you to think that everybody has an overwhelmingly positive experience. There are pros and cons to the operation. Some people have complications. Some people really struggle. I'll tell you my experience of what people say to me when they come back in to see me after a year is they'll say, you know, the first 6 weeks, the first 12 weeks were really hard. This was one of the hardest things I ever did in my life. It was a really hard decision, and then once I made the decision and had the surgery, it was hard to get over the surgery. And really, there were just a lot of changes. And it was hard to adjust to those changes. But once I got over the operation and the weight started coming off, it started to get easier and started to get to be more second nature. And now they'll say, I've lost 100 pounds, I've lost 140 pounds, I've lost 80 pounds. I'm not diabetic anymore. I don't have high blood pressure anymore. They say similar things to what these patients are saying. And then they'll say something to the effect of, you know, this was the best decision I ever made for myself, or I would never go back. I wish I would have done this when I was 20 years younger so that I could have been more active with my kids instead of just being more active with my grandkids. So it's not a minor decision to undertake. It's not all roses, but at the end of the day, it really does make a big impact on your life.
So the risk of death with bariatric surgery is estimated to be approximately 1 in 1,000, which is well below 1%. To give you a perspective, the risk of death with a gallbladder surgery is 7 times higher, at 7 in 1,000. The risk of hip surgery is 9 times higher, at 9 in 1,000, and the risk of coronary artery bypass is 20 times higher, at 20 in 1,000. Furthermore, the mortality rate of a patient who is morbidly obese without surgery is estimated to be 4.5% per year, meaning of those patients, approximately 5 patients will die within that year without surgery versus 1% per year after surgery.
A really common side effect that people see after the gastric bypass in particular is called dumping syndrome. And what happens with this is that when someone eats something really sweet, high concentrated carb, after they've had gastric bypass surgery, it makes them feel really sick. And what's happening is that sugar, which is normally kind of pre-processed by the stomach, really doesn't have time with the gastric bypass stomach to have any processing done to it, and it gets presented almost immediately to the small intestine. Then what that does is sugar gets into the small intestine, hormonal signals go out into the body and say, send for the cavalry, something horrible is going on. We got this huge sugar load that we didn't expect. Those hormone signals cause a lot of blood flow to go into the intestine. Which causes you to get lightheaded. It causes your intestine to cramp. You get nausea, sometimes vomiting, often diarrhea, sweating, increased heart rate. And all of this happens because you had like one Hershey's Kiss. And so this is a really powerful stimulus to tell people that they've eaten the wrong thing. About 75% of people who have gastric bypass get this. This in my mind, maybe one of the reasons why gastric bypass is a little bit more powerful from a weight loss standpoint than a sleeve gastrectomy. I will tell you that almost 100% of people who have a gastric bypass try this out, and by the time they come back in for their 3-month post-op visit, have a story to tell me about their dumping syndrome experience. And so it's not dangerous, but it feels horrible and is very powerful reminder to not eat concentrated sweets after weight loss surgery. So anytime you have any procedure, whether it's weight loss surgery or any other operation, you should weigh the risks and the benefits of that operation. And this chart just shows typical outcomes and then some complications that we see with the gastric bypass or the sleeve gastrectomy. And probably the easiest outcome to look at is weight loss. With the gastric bypass is about 70% on average. The sleeve gastrectomy is about 60% of excess body weight loss. The hospital stay for both operations is in the 1 to 2 day range typically. The risks are pretty similar. The risk of a leak is about 1% in each operation. The risk of a blood clot is about 1%. Ulcers, more common in gastric bypass, 5 to 10%. Strictures with a gastric bypass are in the 5 or 6% range, with the sleeve much less, about 2%. Bowel obstructions, a little bit more common in the gastric bypass because of the rerouting. They're both very successful operations. The failure rate's about 10%. But overall, the gastric bypass is just a little bit bigger of an operation, has a little bit bigger risk profile. But for that, on average, people lose a little bit more weight. And again, the bypass is significantly better for reflux, maybe a little bit better for diabetes than the sleeve.
Pre-operative evaluation. This information session is considered one of our educational seminars that are required prior to proceeding with surgery. You will also have a consultation with one of our surgeons, myself or Dr. Lee, of course, prior to proceeding through the program. You will be seen by the providers in our multidisciplinary team, the dietitian, the psychologist. We also offer support groups, both pre and post surgery. You will meet with some of our administrative providers to help in regards to your insurance coverage and navigating you through that process. We will also obtain some baseline laboratory testing, as well as even some imaging and even an endoscopy potentially prior to proceeding with surgery. Due to its benefit, most insurance companies are now offering coverage for bariatric surgery. Insurance companies all have their own internal criteria for coverage, and the documentation that is necessary prior to proceeding with surgery, as well as the documentation that is necessary for non-surgical weight loss attempts. Usually we wait to schedule surgery until after insurance approval. And of course, our office assists in navigating the patients through this process to ensure their success with approval. We also help with insurance appeals for those patients who unfortunately are not approved for surgery. So what can you do next? We would suggest that you talk with your loved ones as well as your primary doctor to see if they think this is the best choice for you. Prepare for your insurance pre-certification and requirements. We would ask that you start a daily multivitamin such as the Centrum, and as you get closer to surgery, start investigating some of the bariatric formulas available. One must stop smoking prior to surgery, as smoking can lead to complications following the operation, such as strictures and ulcers, as well as issues with wound healing and wound infections. We do test patients for nicotine levels while in the program and prior to surgery, and therefore patients must quit within 3 months prior to their operation. Supplementation is very important after surgery, and therefore we recommend patients start protein diet supplements in the form of protein shakes, as even protein powders that can be added to soups and other foods. It is important to start an exercise program, even if this consists of just walking 30 minutes a day. And although not required, we do prefer that patients have some level of weight loss prior to surgery, with a goal of at least 5% weight loss.